we've got some huge number of New Zealanders now who are diagnosing themselves or looking at the symptoms and going, oh my God, I've got ADD, ADHD. Are you back, Luke?
Thanks.
Are you back?
Good. Yeah.
Okay, cool.
You got me?
Yep, I have. I was just asking the last question. It was, we've got Auckland and Otago medical schools. They've been turning out graduates from Yonks, I think, God, since the 1870s or 80s at Otago. Why aren't they meeting the need of the New Zealand medical system?
I think it's two things. I mean, firstly, they produce excellent doctors, to be very clear, but they're not funded to produce sufficiently. They would admit that. They have said that they have scope to train more, but they probably have had focus on the bigger cities and the placements within bigger city hospitals for their students, which does decrease the exposure to rural work and primary care work.
Right, I know. Okay, so just all right. Thank you for that. That explains why you wanted it Hamilton, and the government's talking about putting it there. Good, I understand that for the first time now. Listen, ADD, ADHD. Just to declare an interest, my son has been clinically diagnosed by a child psychologist with this and is on daily medication. And I have to say, it's made an absolute difference. He's 15 years of age, and he's doing well, but, thank God. But there's been a plethora of ADD, ADHD cases in this country. Large number of adults now are saying, oh, my God, recognising symptoms that they've lived with for much of their lives, and are now trying to get access to those services, which they hope will make better lives. I've just read a review about the cost of ADD. A Deloitte's report published in 2019 found that the total cost of ADD, ADHD in Australia was estimated to be $24.4 billion as a result of people not being treated and of acting inappropriately or not to their full potential. And I would assume that that's probably similar for New Zealand as well, not the total cost, but the proportionate cost.
Yeah, to the scale, absolutely. Absolutely.
Okay, first of all, you're a doctor. Why is there this proliferation of ADD, ADHD in this country? Is it something in the water? Or is it that we're finally recognising something that's been there all the time?
I think it's the latter. I think we probably had a good idea, especially in boys in childhood when ADHD was there often, especially if they had the hyperactivity component, because it's attention deficit hyperactivity, and they are two different scales often with crossover. And so those hyperactive kids we could pick up because they were the ones climbing over the classrooms, and they come into my room and pull the pictures off the walls, and that, just into everything. So we knew those, but we weren't necessarily picking up the attention deficit. We were just they were bumping along in class, not doing particularly well, and it was just assumed that was the way. And there was this assumption that it somehow magically ended in your late teens. But what we're seeing quite clearly internationally is of course, it doesn't. Actually, those effects from the way your brain works continue throughout your working life, and that is where those impacts have on the economy. We know in terms of education and outcomes it's huge. A prison population, we believe, is massively overrepresentative of the ADHD community, and they are hugely underdiagnosed. The MSP and social welfare component will have people who repeatedly can't hold down jobs or don't do so well in employment because they are not diagnosed and not managed in terms of medication and supports, and that's where we believe the real opportunities are for the population.
Well, so okay, but the crazy part of this is I've got to go to a psychiatrist, not a psychologist, a psychiatrist first to get diagnosed and then to get prescriptions. And once you're in the prescription line, there are so many hurdles to jump over to continue to be on prescription for a long time. And it's just, it's crazy. Why can't something be done about this?
Yeah, that's a very good question. And that's what we're trying to change. If you look at it, it was changed back in the late 1990s with the stimulant medications coming online, and the belief that we would lead to overdiagnosis and prescription and a diversion into the methamphetamine market, stimulant market. And we are just not seeing that. They're not used to make methamphetamine speed. They're not drugs of abuse. The evidence of diversion is very sparse. A diversion meaning that people take a prescription and then sell it for a street value. And it's believed what is diverted is actually being diverted into people who can't get a diagnosis for ADHD and are taking it in order to be able to function properly in life. So, and to be clear and fair, it is not a quick diagnosis. This is not something that we're advocating will occur in your normal 15-minute GP appointment. It does.
Which is how I get my antidepressants.
Yeah, I'm hoping that some of that comes from your relationship with your doctor who's known you over time.
No, I'm not saying me personally. I'm not on antidepressants, but I'm saying that you know, I turn up there and you know, antidepressants seem to be.
Yeah, well, that's the other thing. Often we're managing these patients with ADHD with antidepressants and medicines. They're taking illicit medications or illicit drugs, cannabis and the like, thinking that because it slows their brain down. So we've got an increased use of drugs. So yeah, the idea of that appointment is not right for this week. It does take longer. It takes an initial detailed assessment of up to an hour, and then it takes analysis of questionnaires by employers or partners or teachers, and that sort of diagnosis of discussion about treatment. But that is doable. There are other models where general practice, you know, step in and do that kind of work. In skin cancer, for instance, you know, skin cancer surgeries we do are not in 15 minutes. In menopause management, in long-acting contraceptives. So the 15-minute model is not stuck to us. And by changing the Gazette and saying, actually, you're a vocationally registered GP, the college has got it in their training, you're doing your continuous medical education, you are up to date with this, you've done your courses, then you can run some clinics for your ADHD patients. Will mean that we don't have people waiting 6 months to access private psychiatry and paying $2,000 in order to get that done for them.
Okay, so I assume that you are petitioning the Minister of Health, Shane Reti, for some sort of relaxation to make sure that, you can have a number of because you can't suddenly magic a new series of psychiatrists, and yet they're the gatekeeper of this particular issue. Could there be a group of psychologists who could be given that particular role or responsibility?
Yeah, so, I mean, the psychologists definitely play a role, especially in helping us to identify those patients who have indeterminate diagnoses with a modified Conners score. So in terms of the lobbying, what we're saying is, first of all, the renewal criteria from Pharmac needs to go, which means that these people don't need to be reassessed by a psychiatrist every 2 years. It's likely to be a lifelong diagnosis. Your GP can make sure that the treatment is appropriate and can be continued. So that needs to go. The second thing is who can diagnose and prescribe. There's a much bigger body of work there around prescriptions for psychologists. Traditionally, psychologists do not prescribe. They don't have pharmacology training. They don't understand through their learnings the interactions of other medications, etc. But there is a role in the diagnosis for psychologists. But similarly, for GPs, you're right, we can't train the psychiatrists to do it. They're absolutely inundated. Most public services, old DHB services won't do adult ADHD, and so these patients have to seek private care. And so the answer is, let's change the Gazette. We'll include vocationally trained GPs and increase the access, therefore, to people who are trained to do the diagnosis.
Does this require a policy change from Wellington, or is this something that you expect to still have to lobby on?
It does. It requires a change in the Gazette. It's a Gazette notice and one of the laws rather than a full law change. The way we see it in the current environment, there's no cost to government from changing it, and there should only be gains to the social fabric. So we see it as a win-win.